Good morning, good evening, my dear friends. How are you doing? Good evening, friends. I hope all of you are doing good. Am I audible? A very good evening to all of you, and welcome to today's session in which we are going to discuss 25 most important clinical questions, the type of the questions which will be helpful for you in your upcoming exam. The purpose of this session is to make it as high yield as possible, because now is the time when every minute of yours is important. So my whole effort is that whatever time you are spending in this session should be very, very fruitful for you. It should give you a good revision of all the high yield topics in the ophthalmology, and it should boost your preparation, give you confidence that yes, you can do perfectly well in your exam. Okay, so with this beta, I'm going to start the session. Is everybody ready to discuss? Let's make it a very interactive session, and let's try to be fully attentive, make best use of this session beta. Okay, all right. Okay, perfect beta. So let's go to our first question, the discussion of the first question here. Just give me a second. I just wanted to remove this here. All right, beta. So the first question statement is a patient who has undergone cataract surgery in the right eye is now complaining of painless decrease in the vision in the same eye. Which of the following is not the likely cause of decreased vision? Which of the following is not the likely cause of decreased vision? Now, recently in the recent exams, you must have seen the most of us are getting long statement questions, beta, which take a time. So be prepared to be in a habit of quickly reading the question statement, but still reading it very carefully, trying to pick up the key points, trying to pick up the things which will help you in solving the question. So first of all, here the most important thing which you should see here is that the patient has undergone cataract surgery. Okay, the patient has undergone cataract surgery. So most likely it is related to some complication of the cataract surgery. Now what is happening? There is decrease in the vision in the same eye, but very, very important point here is painless decrease in the vision beta. Painless decrease in the vision. So we have to pick up a cause which does not cause painless decrease. So let us see what are the choices here. So choices here are, the first one is posterior capsular opacification. The second one is Irwin gas syndrome. Then we have acute post-operative endophthalmitis and retinal detachment. So as I can see here, there is a little bit of confusion in your mind. Let's clear this confusion. So key point is, as I'm telling you, painless decrease in the vision beta. All of these, they are complications of cataract surgery. All of these, they can cause decrease in the vision, but in which scenario there will be pain associated. So pain is always associated when there is inflammation in the eye beta. when there is inflammation in the eye. So when there is inflammation in the eye, so there will be painful decrease, and as some of you have already marked the clear answer, so the answer in this case is beta, acute postoperative endophthalmitis. Okay, acute endophthalmitis, because that is a suppurative inflammation and infection after the cataract surgery, in which there is inflammation in the anterior segment, inflammation in the posterior segment. So that causes painful red eye with decreased vision. Okay, so that is how we are able to reach answer in this question, beta. So coming to the complications of the cataract surgery, bache, that is an important topic for your exams. So there can be multiple causes of the decreased vision after cataract surgery. So one of the most common causes of decreased vision after cataract surgery is beta, posterior capsular opacification. Posterior capsular opacification, which is also called as after cataract, in which the posterior capsule becomes opaque. The opacification can be in the form of Elschnig pearls, as you are seeing here, or less commonly as Sommering ring. So once the capsule becomes opaque, again the patient will have decrease in vision. And the treatment of posterior capsular opacification is, we do a laser capsulotomy. So what is the treatment? All of you know, we do a laser capsulotomy using ND YAG laser. We will make an opening again in the center of the posterior capsule so that the vision becomes clear again. But this is a painless cause. There will be no pain. Patient will have slowly progressive decrease in the vision after few months or even few years after the cataract surgery. Remember? Then another important complication is development of cystoid macular edema. The cystoid macular edema, which develops after cataract surgery, is given the name Irwin-Gass syndrome. Again, this has been one of the past questions also, beta, has been asked in the NEET PG. So this remains itself as a question topic. So what happens after few weeks or months even after of the cataract surgery? There is development of cystoid spaces in the macular area. So as you see these cystoid spaces, so this type of the cystoid macular edema after cataract surgery is called Irwin-Gass syndrome. But this will again cause painless decrease in the vision. Alright, and the treatment of this is giving anti-inflammatory drugs. So you can give non-steroidal anti-inflammatory drugs. Sometimes you have to give steroids as well, or even the posterior subtenon injection of the steroid. Okay? And if we do FFA in this case, beta, can you tell me what will be the FFA finding in this case? So FFA in this case will give us a flower petal appearance. FFA in this case will give a flower petal leakage, right? So these are the few points related to this question, which again can be asked as a question itself. Now coming to our choice, the correct choice here, which is acute post-op endophthalmitis. Acute post-op endophthalmitis is a very sight-threatening complication of the cataract surgery. So this can come as a clinical case scenario as well, beta. So what can be the clinical case scenario? That a patient underwent cataract surgery 3 days back, okay, and now the patient has painful red eye. So painful red eye, decreased vision, and on examination you will see all the features of the inflammation. Conjunctival congestion, there will be anterior chamber reaction in the form of the cells and the flare. As you can see, there is hypopyon, there will be vitreous exudates. So this is an ocular emergency. The most common cause of acute post-op endophthalmitis is? Friends, can you tell me the most common cause of acute post-op endophthalmitis? that is staph epidermidis. Staph epidermidis, which is actually a commensal of the lid skin, and it's a conjunctival flora, normal conjunctival flora. So to prevent such a sight-threatening complication, we do pre-operative povidone iodine antisepsis. Okay, so we clean the area, the eyelid skin area before the cataract surgery with 10% iodine. We put 5% povidone iodine solution in the conjunctival sac to prevent the complication of post-op endophthalmitis. Okay? So with this question, beta, I have tried that you could revise the complications related to the cataract surgery, and acute post-op endophthalmitis will cause painful decrease in the vision. So that is the answer in this question. Yes, very nice, Dr. Smooth Specialist. So when it is more than, actually within 1 week, we call, within 7 days, we call it as acute endophthalmitis beta. When it is more than 7 days, then it is called as chronic endophthalmitis. So then propionobacterium and fungi are the main causes. Absolutely right. Okay? Chale, let's move on to next question. So everybody has their concept clear related to this question? Alright, so we are ready to move to the next question. Let me take you to the next question, beta. Alright. So here the second question is, a patient comes to IOPT with pain, redness, decrease in vision. So every question, see, every word in the question statement is important, bache. So again, this patient is having pain, redness and decreased vision in the right eye. So painful red eye with decreased vision. What are the findings on examination? What are the findings of examination? Good evening, my dear friends. Yeah, there was a little bit of lagging, but I think that should be fine now. Is that okay? Okay, chale, let's go to the question. So on examination, findings क्या है slit lamp examination बेटा? Again आप ध्यान से देखें, aqueous flare and cells. Okay, so it means there is inflammation in the anterior chamber. Fine keratic precipitates. अब आपने जब ये वाला word एक बार देख लिया, fine keratic precipitates, so you know keratic precipitates are hallmark of, keratic precipitates, KPs are hallmark of anterior uveitis. Anterior uveitis. So this patient has anterior uveitis. Okay. Intraocular pressure is 34 millimeter of mercury. 34 millimeter of mercury. Which of the following drugs will not be used in the treatment of this case? ठीक है, तो पहले तो बेटा आप अपना diagnosis confirm करें. Okay, so first of all confirm your diagnosis कि diagnosis क्या है. अब keratic precipitate की वजह से, keratic precipitates की वजह से, you know it's a case of anterior uveitis. ठीक है, absolutely right. Now in anterior uveitis, pressure is also high. You know, glaucoma can be one complication of anterior uveitis. So this is a case of anterior uveitis plus glaucoma, high pressure. Okay, so the treatment will be to control the inflammation and to control the eye pressure. ठीक है, अब choices पे आए. Topical steroids. Yes, you will be giving topical steroids because topical steroids will control inflammation. That is the mainstay of treatment of anterior uveitis. Travoprost. So travoprost क्या है बेटा? Prostaglandin analog, which is one of the anti-glaucoma medication used to lower intraocular pressure. But is this the correct drug to control the intraocular pressure in this case? No. Why? Because here the pressure is increased in the presence of inflammation, and prostaglandin analogs can worsen the inflammations. They are not recommended when there is inflammation present, uveitis present, cystoid macular edema present. That is rather almost the only contraindication for prostaglandin analog. So that is, we will not be using this as a anti-glaucoma drug for this particular case. Atropine, yes, it is used because that is a cycloplegic that will reduce inflammation, relieve ciliary spasm. Timolol, a beta blocker, that does not have any side effect of increasing the inflammation, so that can be safely used when there is high pressure in a case of glaucoma. So your answer is travoprost beta, B. Okay, right? So pilocarpine and prostaglandin analogs are two anti-glaucoma drugs which we are going to avoid if there is high pressure in the presence of inflammation. क्लियर है बेटा, ये कॉन्सेप्ट क्लियर है? बिकॉज एंटी ग्लाइकोमा ड्रग्स itself they are your important topics. You must know their contraindications. Anterior uveitis itself is an important topic. So from the clinical case statement, you should be able to make a diagnosis of anterior uveitis. And then you should know if there is high pressure in anterior uveitis, which is the drug of choice. ठीक है? Yeah, so yes, very right. Atropine can also be used whenever there is corneal ulceration. So whenever there is inflammation, cycloplegics, they are preferred in anterior uveitis, in corneal ulcers, and yes, very nice. Malignant glaucoma is the only type of the glaucoma where we give atropine. So very good. It means your foundation in ophthalmology is good. You understand the concept. Okay. Now I just want to take you through a slit lamp picture of anterior uveitis as well. In your last exam beta, पीछे जो January में हुआ है, there were lot of questions based upon the anterior uveitis, 2 or 3 of them, a mix of the questions. So you should be able to diagnose if there is a slit lamp picture or in the clinical case scenario. So in anterior uveitis, you will have painful decrease in the vision, red eye, ठीक है? Quickly एक बार इसको भी आप रिवाइज कर लीजिए. Anterior uveitis, and there will be cells and flare in the aqueous. Okay, so यहाँ पे हो सकता है कि you are not able to see very clearly, but there will be on slit lamp examination cells and flare in the aqueous. And here what you are seeing, the keratic precipitates, the KPs. So KPs are hallmark of anterior uveitis. So that is how you will diagnose anterior uveitis on a slit lamp examination. And there can be even irregular pupil because of the posterior synecdoche. Irregular pupil because of the posterior synecdoche. So that can also be given in your slit lamp examination. ठीक है जी? Right beta? Okay. All right, so moving on to your next question, bache. So purposely I am giving you the questions which are based upon the clinical case statements, because this is the type, the trend of the question. There will be few questions which will be one-liner. There will be few questions which are going to have a little long statement with images. So that is what we expect in the exam. So coming to this question, bache. A lady reports pain on eye movements and decreased vision in the left eye. So again over here beta, what are your key points? Pain on eye movements, decrease in the vision. So again, painful decrease in the vision, specifically when the patient moves the eyeball. What are the signs? On examination, her color vision is defective. Okay. And there is seen relative afferent pupillary defect, RAPD, or Marcus gun pupil. Anterior segment examination is normal. Fundus examination shows the following findings. Okay. So which of the following is the likely diagnosis? So let me see what we are dealing with here. Beta, why do you think that it is the answer is choice B? Any particular reason for choosing the choice B as the answer, beta? Any reason for choosing the because I want to clear your there. Okay, so you think that there is a cherry red spot. Have a look at the fundus image, bache. Have a look at the fundus image. Okay, so whenever we want to look at the fundus image, so even in the classes I have told you, first of all look that whether you are able to see all the fundus details clearly. Yes, you can see. How is your optic disc, beta? The optic disc color is normal, the margins are normal. Okay, so cup is normal, there is no problem in the vessels, macular area is normal. So this fundus examination is absolutely normal. This is a you do not see any abnormality on this fundus picture. It is a normal fundus examination. Okay? So what is the condition? What is the condition? How do I do this? I also want to remove this playback. Okay, how do I remove this playback? Let me check here. Okay, give me a moment, beta. All right, just give me a moment. I'm trying to do this. Then how do I do that? Yeah, I know, beta. It's like I'm not sure why there is this thing over there. So let me continue. Is that okay? Let's bear with this, whatever it is. I'll try to remove the skin, the screen, move the screen so that you are able to see that. Okay. Oh, I'm not technically that strong. ठीक है. Okay, so there is no cherry red spot, beta. There is no cherry red spot. Cherry red spot is a dark spot in your macular area, dark spot in your macular area, along with a pale retina or a white retina. So as I discussed with you, this is a perfectly normal fundus. Okay, so now coming to the choices, beta. So now let's come to the choices which are here. All right, so just give me a moment here, beta. I'm just going to reconnect this thing because something has happened here. Just give me a few seconds here. Okay, hi dear friends, are you able to see the screen now? I'm sorry for the little technical glitch which had happened. So is everything, is it all right now? Okay, okay, perfect. So that was a little glitch, but now I think everything should be good, and we are back here, beta. ठीक है, चले. So let's do with the this question only, because so whenever there is decrease in the vision, RAPD. So whenever there is RAPD, it's always there that there is going to be either an optic nerve disease or and disease which is involving the retina extensively, in which there is severe involvement of the retina. Now in this particular question, beta, so what are they saying? RAPD is there, color vision is defective, decreased vision is there, but retina is normal. Retina is normal. So we are ruling out papilledema, because in papilledema there will be disc edema. In papilledema, there will be disc edema. So there is no disc edema in this case. In central retinal artery occlusion, there will be pale retina with cherry red spot. Again, there is nothing in this fundus image, right? In optic neuritis, there is a type of optic neuritis which is called retrobulbar optic neuritis or retrobulbar neuritis, in which fundus examination is normal. Okay. In glucomatous optic neuropathy, again the optic nerve will show cupping. There is no cupping over here. No increased cupping. The cup is about 0.3 to 0.4 in this case. Okay? So this kind of trick questions they can ask you, beta. So there, do not get confused. Just remember your concept which you have in mind. I always tell in the class that the only condition in which there is decreased vision, RAPD, they may give that color vision is normal or defective. Okay, normal anterior segment examination and normal fundus examination. So when fundus is appearing normal with these symptoms, it is retrobulbar neuritis, which is one of the presentations of optic neuritis. So I purposely put the choice as optic neuritis because retrobulbar is a type of optic neuritis in which the part of the optic nerve which is behind the eyeball is inflamed. So on fundus examination you will see that nerve is appearing normal, fundus is appearing normal. Okay? So please make a note of this. This is case of retrobulbar neuritis. Okay, beta? Right? So don't get confused if there is a question related to that. Most of the time they might not give you fundus picture. They may just write that fundus examination is normal. Even then your answer should be retrobulbar neuritis or optic neuritis. Okay, ji? Right? Chale. Let's move to the next question. Here. A patient with cafe au lait spots on the back is referred for eye examination. Okay, so here again they are giving you, you can see they are giving you the key points in the question statement. The patient is having a skin lesion which is cafe au lait spots. So even with this, and it's a kind of an integrated question of ophtha and internal medicine. So you know cafe au lait spots, they are seen in neurofibromatosis type 1. Anterior segment shows the following findings. So they have sent this patient to us for ophthalmic examination. So what is the anterior segment finding, beta? What is the anterior segment finding? Again, try to go stepwise, quickly but stepwise. Cornea is clear. Okay, so you can see the iris, pupil is normal, regular. What are you seeing on the iris बच्चे? आयरस पे आपको क्या दिख रहा है? ये इस तरह के नोड्यूल्स दिख रहे हैं, right? You are able to see these nodules on the iris. Okay? So these nodules on the iris, which are there in both the eyes here, in the presence of cafe au lait spots. So what are these nodules? These are Lish nodules, beta. These are Lish nodules, which are actually not the inflammatory nodules. These are iris hematomas. Iris hematomas. So cafe au lait spots, Lish nodules. So what is the diagnosis? Neurofibromatosis type 1. Neurofibromatosis type 1. So in this condition, which tumor can occur in the eye? Which of the following tumor is likely to be associated in this condition? Choices are cavernous hemangioma, optic nerve glioma, retinal astrocytoma or lymphoma. ठीक है, बताएं बेटा. So which optic nerve tumor or which retinal tumor can be seen in a patient of neurofibromatosis type 1? That is your optic nerve glioma, beta. Optic nerve glioma, isn't it? है ना? तो ये आपका इंटरनल मेडिसिन और ऑप्थल्मोलॉजी रिलेटेड क्वेश्चन है. दे कैन गिव यू द क्वेश्चन एज अ डायरेक्ट क्वेश्चन एज वेल, or they can give you a question in the form of a clinical case scenario. ठीक है? So optic nerve glioma is the commonly associated optic nerve tumor in the patient of neurofibromatosis type 1. ठीक है? Right? Am I clear, beta? ठीक है जी? Okay, so other question related to optic nerve neurofibromatosis can be there, beta. That is, there can be a lid tumor seen in these cases as well. A lid tumor seen in these cases as well, which is which tumor is here, beta? See the finding in the lid here. Let me show you this picture. So these patients, when they have neurofibroma in the eyelid, bache, neurofibroma in the eyelid, that gives an S-shaped deformity to the eyelid because of plexiform neurofibroma of the eyelid. So that can be another question related to this condition. ठीक है? Yes, absolutely right. This is plexiform neurofibroma giving an S-shaped deformity of the eyelid. This can be sometimes asked as an image-based question as well. So the systemic conditions, neurofibromatosis, Marfan syndrome, and even conditions associated with uveitis like ankylosing spondylitis, VKH syndrome. So you should be having these in mind when there are integrated questions related to ophtha and internal medicine. ठीक है बच्चे? Right? And just for your reference here, hemangiomas, they are more commonly seen in the cases of Sturge-Weber syndrome. Sturge-Weber syndrome. Okay? And retinal astrocytoma, they are seen in the cases of tuberous sclerosis. So these are not that commonly asked, but neurofibromatosis type 1 is commonly asked, बच्चे. ठीक है? चलें. Let's move on to the next question, beta. Let's move on to the next question. Now this question is also related to a clinical case scenario which has been asked in almost every exam. So though it might feel a repetition to you, but I want you to revise this question. I want you to do this question. Let's read the question statement. A 40 years old lady presents in emergency. So it's an ocular emergency. Patient is presenting with headache, vomiting and severe eye pain. Headache, vomiting, severe eye pain. On examination, there is a red eye with cloudy cornea and vertically oval pupil. ठीक है, so this again is a very very important key point here बच्चे, vertically oval pupil. Intraocular pressure is 58 millimeter of mercury, high range, anterior chamber is shallow. तो ये सारे पॉइंट्स आपको अगर मिल रहे हैं तो आई एम श्योर देयर शुड नॉट बी एनी difficulty in making the diagnosis. There is also history of episodes of colored halos. So painful red eye, very high intraocular pressure, shallow anterior chamber, vertically oval pupil. Because of the very high pressure, cornea is cloudy or edematous. So what is the diagnosis beta? तो सबसे पहले diagnosis क्या है? Acute congestive glaucoma. ठीक है? Everybody agrees with me? It is acute congestive glaucoma. So question related to that can come in your upcoming exam as well. Now the question is related to which is not the recommended management in this case. Choices are intravenous mannitol, laser trabeculoplasty, pilocarpine, laser iridotomy. So I'm seeing there is confusion between the B and C choice. So C देखो बेटा, अगर आपने C मार्क किया तो pilocarpine तो is the management of this condition. ठीक है, because why acute congestive glaucoma is happening? Because whenever pupil dilates, there is pupil block. There is pupil block. So you want to constrict the pupil, and that constriction of the pupil is achieved by pilocarpine. So pilocarpine is used. That is the management of acute congestive glaucoma. Similarly, because pressure is very very high, so you want to reduce the pressure rapidly, otherwise optic nerve will be damaged. So intravenous mannitol is the treatment for this condition. And once the acute attack of acute congestive glaucoma subsides, to prevent the future attacks, we do laser iridotomy. Okay, but laser trabeculoplasty has no role in this condition. Laser trabeculoplasty has no role. So B is the answer. Laser trabeculoplasty is the type of the laser which is used in cases of open angle glaucoma beta. ठीक है, so this is a case of acute angle closure glaucoma. ठीक है, am I clear to everyone which had the doubt? Yes, you are very right. Trabeculoplasty or laser trabeculoplasty is the procedure for open angle glaucoma. Yes, again atropine will also be contraindicated because you don't want to keep the pupil dilated. You want the pupil to be constricted beta. ठीक है, so it's very very important to identify this diagnosis, okay, and to know the management of acute congestive glaucoma. The patient will have very typical presentation, severe headache, pain, vomiting because of such a high pressure. Okay. Usually the attacks, they are precipitated when patient remains in dark conditions for long time, like watching a movie in the theater, or somebody accidentally put atropine in the patients who have narrow angles. Okay, so once the pupil is dilated, there is attack of acute angle closure glaucoma. Pupil becomes mid-dilated, vertically oval because of the ischemia of the iris sphincter. Cornea will be hazy because of the edema. There is anterior chamber which is very very shallow. Okay, so you control it by giving intravenous mannitol, pilocarpine. Once the attack is controlled, the patient is started on the other anti-glaucoma drug, and to prevent the future attacks, we do a peripheral laser iridotomy. Okay, by again using ND-YAG laser, and this should be done in both eyes of the patient beta. So that is also an important point. Not only the eye which had the attack of acute congestive glaucoma, because the other eye will also have narrow angles. The other eye is also prone to develop same condition. So we do ND-YAG laser iridotomy in both eyes. Okay, right? And yes, when patient has repetitive acute attacks, then the condition can become chronic, which leads to the Vaux triad there. ठीक है जी, very nice. So anything related to acute congestive glaucoma is again very important for you to understand and to remember beta. चलिए नेक्स्ट क्वेश्चन पे आते हैं. विच ऑफ द फॉलोइंग इज नॉट अ लाइकली कॉज ऑफ द कंडीशन शोन इन द गिवन इमेज. सो ऑप्थेल्मोलॉजी में बेटा बहुत सारे क्वेश्चंस यू विल गेट इन विच दे शो यू एन इमेज. Based upon the image, you have to make a diagnosis, and then the question is related to, okay, so based upon that diagnosis, there is a question which is being asked. So again, first of all, we have to identify what is the condition in this image. Okay? So you are seeing both eyes of this patient. Okay, so this is the left eye of the patient, this is the right eye of the patient. So what is the diagnosis? What is the abnormality? First of all, you have to tell me. So as you can see, the right eye is deviated inward. The right eye is deviated inward. Left eye is in the center. Even if you look at the Hirschberg, you can revise your Hirschberg as well. The corneal reflex is in the center of the pupil in the left eye. So there is no squint in the left eye, whereas the corneal reflex is almost at the limbus in the right eye. So there is right eye convergent squint or esotropia. ठीक है, confirm. Now which of the following is not going to cause esotropia? Congenital esotropia. The very name is telling you the diagnosis, so that will cause squint. Sixth nerve palsy. So sixth nerve palsy leads to lateral rectus muscle weakness. So when lateral rectus muscle is weak, the eye will become again convergent. So you will see convergent squint in sixth nerve palsy. Congenital third nerve palsy. Now third nerve palsy does not supply lateral rectus muscle. Okay, it does not supply superior oblique muscle. So in congenital third nerve palsy, the eye is in down and out position. It is in exotropia position, not convergent position. It is in down and out position. Then high AC by A ratio. AC by A ratio means accommodative convergence. When accommodative convergence in a child is out of proportion to the accommodation, so that is one of the causes of accommodative esotropia. So whenever the patient is looking at near, the eyes they go into convergent squint. So that can also cause convergent squint. Okay? So your answer is congenital third nerve palsy. Congenital third nerve palsy, because all the other choices A, B and D, they can cause esotropia or convergent squint. ठीक है जी, right? Any doubts about this? And yes, it is about 45 degree of the squint. Based upon the Hirschberg test, it is 45 degree of the squint. Yes, that's right. Yeah, most common cause is the hypermetropia, which is a refractive type of the accommodative esotropia. ठीक है बेटा? Very nice. So all of you have your concept clear about the third nerve palsy as well. So just to show you, as you see here, in third nerve palsy, the eye is in down and out position. And because of the involvement of the LPS nerve, there is ptosis as well. It does not cause convergent squint or esotropia. Convergent squint will be seen in the cases of sixth nerve palsy. ठीक है बेटा? Right? Yeah, there is ptosis as well, as you can see here. Okay? चले आगे बढ़ते हैं. Moving on to the next question बेटा. Again a simple question, but they can ask you it in a little different way, as you see here. So what's the question statement? The question statement is, a 67-year-old man presents with sudden painless decrease in vision. Okay, so an elderly man, and now it is a sudden painless decrease in the vision. On examination, the best corrected visual acuity is 6/60. So it means the vision is reduced quite a bit. And there is RAPT, the relative afferent pupillary defect. For fundus examination shows the following findings. So fundus images, fundus pictures are important, beta, of the especially the typical diseases. So you should be able to identify those diseases based upon the fundus examination. There is history of uncontrolled hypertension. Which of the following is not true of the given condition? So you have to pick up the false statement about the given condition. पर statement pick up करने से पहले make a diagnosis. Make a diagnosis. So what is your diagnosis first of all in this case, बच्चे? Yes, very right. So as you can see, the whole of the fundus is filled with the retinal hemorrhages. Hemorrhages in all the four quadrants, flame shaped, dot plot hemorrhages, as if the tomato has been splashed on the fundus. So tomato splash appearance of the fundus, painless decrease in vision. So that is a feature of CRVO, central retinal vein occlusion. Absolutely right. अब choices पे आ जाते हैं. Intravitreal anti-VEGF is the preferred treatment. Yes, that's true, because these patients, they develop macular edema, and to control the macular edema, we give intravitreal anti-VEGF injections. These patients, they can develop neovascular glaucoma. Again, a true statement. Because of the retinal ischemia, these patients, they will produce more VEGF, and if they are not treated, that leads to iris neovascularization and neovascular glaucoma, which is also cause 90-day or 100-day glaucoma in these cases. Okay? These patients, they can develop vitreous hemorrhage. Again, a true statement, because if there is neovascularization on the retina, like NVD or NVE, that can lead to bleeding into the vitreous cavity. So that is why you have to do anti-VEGF injections in these cases. Fundus fluorescent angiography will be normal. Now this is a false statement, okay? Because there is a vein occlusion. So retinal vein is occluded. So obviously angiography will not be normal. You will see that the blood flow in the vein is delayed because of the occlusion. So that will not be normal. Okay? So the questions, they can be asked based upon the diagnosis, based upon the management, beta. Okay? So I hope you should be able to attempt these kind of questions if they come. Okay? Right? So this is your central vein occlusion, beta. Fine? चलें आगे बढ़ते हैं. Coming to the next question, बच्चे. All good with this question? Yeah, because hypertension, uncontrolled hypertension, is one of the major risk factors for the vein occlusions, बच्चे. Fine. चलें. Next question, beta. A 12-year-old girl is brought to the emergency with history of high-grade fever. High-grade fever. So be prepared for long question statement, bache. A young girl coming to the emergency with high-grade fever. Her left eye is tender with periorbital swelling and with bulging of the eyeball. So every word, beta, bahut attention se you have to read in the exam. In exam, we know everybody is hyper overexcited, but read every word in the question statement very carefully. Okay? So eye is tender, so pain, periorbital swelling, bulging of the eyeball means proptosis. So there is painful proptosis. Painful proptosis. So this is how you will, in your mind, align the things according to what you have read. ठीक है? Examination पे क्या पता चल रहा है? Movements in the eye, they are restricted. Extraocular movements are restricted, and there is a relative afferent pupillary defect, means there is optic nerve involvement. History of recurrent sinus infection. अब ये एक बार आ गया तो again that gives you a clue to your diagnosis. So painful proptosis, restricted eye movements, RAPT. Okay. So what is the possible diagnosis in these cases? Choices are orbital cellulitis, preseptal cellulitis, blepharitis. So as you can see, this involves the involvement of the deep orbital tissues. Okay, it's not superficial, it is not just involving the eyelids, it is not involving the preseptal area of the orbit. The infection is deep to the orbital septum. So this is, as you are telling me very rightly, orbital cellulitis. Okay, because this is the condition where there is inflammation, suppurative inflammation of the tissues which are deeper to the orbital septum. So there is painful proptosis which will not be seen in preseptal cellulitis. Preseptal cellulitis will have some pain, but there will be only lid swelling, no proptosis. There will be no restriction of the no proptosis here, no restriction of the extraocular movements. Okay, no RAPD. So that is how you will differentiate preseptal cellulitis from orbital cellulitis beta. ठीक है, स्टाई आपको पता ही है, स्टाई इज जस्ट a small painful nodule on the lid margin. Again, ये सारे फीचर्स स्टाई में नहीं होंगे. Blepharitis is when there is inflammation of the lid area only, eyelid margins. Again, ये सारे फीचर्स उसमें नहीं होंगे. ठीक है, so you have to be very careful. What is the most common source of infection in the cases of orbital cellulitis? As you are telling me, that is because sinus areas, they are adjacent to this orbital area. So ethmoidal sinus infection, if it is there, that is very likely to spread to the orbit, which can cause orbital cellulitis, which is the most common cause. So this image here is showing you how the extraocular movements are restricted. So you can see here periorbital swelling beta. You can see conjunctival chemosis, proptosis, and patient is not able to move the eye up, so restriction of the eye movements. So it's an ocular emergency. You will hospitalize the patient, you will start the patient on intravenous antibiotics. At the same time, you will do an ENT consult to treat the underlying cause, which is most likely the ethmoidal sinusitis. ठीक है जी, चले, हो गया ये वाला टॉपिक भी रिवाइज आपका. Along with that, you have dealt with few other things as well. Moving to the next question, bache. Moving to the next question. A young boy is diagnosed with squint in the left eye. Okay, so there is a patient who is having squint. All of the following tests can be used for confirming the suppression of the eye except suppression of the eye एक्सेप्ट. सो क्वेश्चंस में बेटा जहाँ पे एक्सेप्ट आएगा वो चीज़ को अगेन बहुत ध्यान से वेरी केयरफुली रीड द लास्ट लाइन ऑफ द क्वेश्चन व्हाट दे आर आस्किंग. सो अ पेशेंट हु इज हैविंग अ स्क्विंट, यू नो that can cause suppression of the vision in the squinted eye because the squinted eye does not take the central fixation, and if the squint is not corrected, the brain starts suppressing the image of that eye. So how would we know that the eye has suppressed? Okay, so there are certain tests which we can do to check whether binocular vision is normal or not, whether one eye is suppressed or not. So which one are those? Choices are Worth4 dot test, duochrome test, Bagolini striated glasses, synaptophore. So which of these tests is not a test for suppression beta? Which of these tests is not a test of suppression? बताएं. Yes, B beta, B. ठीक है, डॉक्टर रेड्डी कंफ्यूज नहीं होना. D, synaptophore can be used for checking the suppression. ठीक है, B आप सही बता रहे हैं. That is your duochrome test. Duochrome test. ठीक है, चलें थोड़ा सा इसके बारे में जान लेते हैं. So what is duochrome test? Duochrome test is basically used to refine the glass prescription. So this is your duochrome test, बच्चे. So recently they have been asking questions more related to squint, neuro-ophtha as well. So ये थोड़ा सा रिवाइज कर लें. So in duochrome test, what we do, once you have given glass prescription to the patient, you ask the patient to look at this chart. in which few letters they are written on a red background and few letters they are written on a green background. So that helps us to refine the spherical correction, that you have not over corrected the patient to myopia or to hypermetropia. Okay, so the patient should have both the on the red background and on the green background the letters they should be equally clear. ठीक है, इतना ही अगर आप याद रखें तो भी ठीक है. But if you want to know more, if green is more clear as compared to the red, then it means you have corrected more towards the myopic side. ठीक है, तो आप उसको थोड़ा सा अंडर करेक्ट करेंगे. इफ रेड अपीयर्स मोर क्लियरर देन द ग्रीन, देन यू हैव करेक्टेड मोर टुवर्ड्स द हाइपरमेट्रोपिक साइड. सो अगेन यू विल अंडर करेक्ट दैट. सो यू विल डू द फाइन spherical verification or correction based upon this, but this is not a test for suppression. Okay, so the test for suppression is we do Worth 4-dot test. Worth 4-dot test. So this is your 4-dot test in which patient wears the red and green glasses. Red and green glasses. The red is in front of the right eye and the green is in front of the left eye, and they see on a box which has these 4 lights. So if one of the eye is suppressed, if left eye is suppressed, the patient will see only 2 red lights. If right eye is suppressed, the patient will see 3 green lights. Okay, and in the double vision patient will see 5 lights. So this is one test which can be used to check for suppression for normal binocular single vision and for double vision. ठीक है, right? Similarly, we have Bagolini striated glasses. So these glasses, they have fine striations, and the patient then is shown a torchlight and the type of the reflex which patient sees. So if the patient sees only a single, normally they should see this cross. The striation on the glasses, they make the light appears as a cross. So if they see only single line, it means one eye is suppressed. ठीक है, तो अगर आप बहुत डिटेल नहीं भी याद रख पाए अबाउट द टेस्ट, at least you should remember that which are the tests which you can use to check for the suppression. Worth 4-dot test, Bagolini striated glasses. Similarly, in synaptophore, you can show them the slides where you can check that whether the 2 eyes they are fusing normally or not. But duochrome test is the test for refining the spherical power in the glass prescription. ठीक है, right? I know ये थोड़ा सा हटके क्वेश्चन है, but they have been asking these kind of the questions in the exam बच्चे. ठीक है, चलें आगे बढ़ते हैं. Okay, so coming to a question which I am sure you know very well. ठीक है, चलें. A 36 years old man is suffering from epiphora. Epiphora क्या है? Epiphora means excessive watering from the eye due to some obstruction. A recurrent swelling in the lacrimal sac area. So lacrimal sac area में swelling भी रहती है patient को. On syringing, so when you do the syringing test, a hard block is felt on advancing the cannula through the lower punctum. So you know in syringing you are putting a cannula through the punctum, you are advancing the cannula and then a hard block is felt. Okay, and when you inject the fluid mixed with pus regurgitates from the opposite punctum. Okay, so based upon your interpretation of the syringing test, what is the diagnosis in this case? Okay, so when you see a hard block, so hard block means nasolacrimal duct obstruction beta. Okay, and the fluid, because the fluid which has been collected in the lacrimal sac area, that becomes little infected, so it is mixed with the blood and it comes out through the opposite punctum. So that is the diagnosis in these cases is NLD obstruction. NLD obstruction, and it's a complete obstruction because whole of it is coming through the opposite punctum. So what is the most appropriate management? I told you everyone will be giving the answer very correctly. Yes, the treatment is DCR or decrocystorhinostomy. Okay, because NLD is obstructed, so you will be bypassing the NLD, you will be creating an opening between the lacrimal sac and the middle meatus area. Okay. Conjunctival DCR. Conjunctival DCR is the procedure which we do when there is common canalicular obstruction. Common canalicular obstruction, not in the cases of NLD obstruction. Punctal plugs. Punctal plugs कहाँ use होते हैं बेटा? Punctal plugs, they are used in very severe dry eye. Very severe dry eye. So what we are doing actually is, when a patient has very severe dry eye, so you want that whatever tears they are being produced, they remain in the conjunctival sac area. So you actually occlude the puncta. Okay, so you put silicone plugs to occlude the puncta. Okay, systemic antibiotics, if there is infection in the lacrimal sac area, you can give systemic antibiotics before you do the DCR, but the definitive treatment of NLD obstruction is DCR. Okay, so I'm sure everybody is very clear about it. And you should also be able to interpret the results of the syringing beta. Okay, so just giving a quick recap, when you do the syringing test, you are putting the cannula in the lower punctum. You are putting the cannula here in the lower punctum beta. If the fluid comes out through the same punctum, through the lower punctum, it means there is obstruction in that canaliculus. Okay, fluid बिल्कुल advance ही नहीं हो रहा है, cannula भी advance नहीं हो रहा है. So this is, it means lower canaliculus is blocked. Similarly, you do the upper one. If upper is blocked, it will come through the upper punctum. Okay, so second is, like, you advance the cannula and you see a soft block. You notice a soft block, and then when you push the fluid, it comes from the opposite punctum. So that indicates common canalicular block. Common canalicular block. ठीक है? Oh, okay. This is, here is that, yeah. So this is when the soft block is noted at very early phase, that about 2 to 4 millimeter. If the soft block is noted at around 6 millimeter or so, then, and again when the fluid comes back from the opposite punctum, so here we go to the hard block beta first, actually. The hard block, and the fluid is coming from the opposite punctum as we were discussing. So that indicates NLD block. NLD block. And sometimes this is complete NLD block. Complete NLD block. Okay? And sometimes there is partial NLD block. Partial NLD block, in which some of the fluid goes and some of the fluid regurgitates, but that indicates partial NLD block. And if there is no blockage, the fluid should, after you see the heart stop, the fluid, they should go into the nasal cavity, and the patient will feel that in the throat. So in these cases, there is no obstruction, there is no block. So you should know the interpretation of the syringing beta. You should know interpretation of the syringing. ठीक है? Right. चलें आगे बढ़ते हैं. Alright, so the question based upon your visual field defect, again I am very sure that all of you would be able to do this. A patient underwent perimetry and the following field defect was seen. What is the likely site of lesion in this case, beta? Likely site of lesion sorry, in this case, let me show you the field defect. This is the field defect. So first of all, identify the field defect, bache. What is the field defect as per you? So this is the name of the field defect, bache. This is homonymous hemianopia, right? Agree with me? Homonymous hemianopia, because in this case, the left half of the visual field is gone. Left half of the visual field is gone. But if you notice, the center is spared. The center is spared. Okay. The type of the visual field defect is left homonymous hemianopia, left-sided homonymous hemianopia with central or macular sparing. ठीक है जी? Agree with me, beta? And this type of the visual field defect is seen in the cases of occipital cortex. When there is macular sparing, so that is seen in the cases of occipital cortex. And the site of the lesion is always contralateral to the side of the field defects or hemianopia. So since it is left-sided homonymous hemianopia, it means the visual field defect is on the right side. Yeah, very nice. I told you almost each one of you will be able to give the right answer here. So it is right occipital cortex, beta. ठीक है, it's not optic tract because in optic tracts we do not get the macula sparing. तो ये आप ध्यान से अगर देखें ना, अगर macula sparing नहीं हो, अगर macula sparing नहीं हो, so the defect will be like this. Then the defect will be like this. But here the center is cleared, बच्चे. The center is clear. So there is central sparing or macular sparing. ठीक है? So this is right occipital cortex. Central optic chiasma, you will be getting bitemporal hemianopia. Okay, for example, in the cases of pituitary adenoma, so you will be getting bitemporal hemianopia. Similarly, in lateral optic chiasma, the lesions, they are rare, but in those cases you will be getting binasal hemianopia. Okay, so again बच्चे, visual field defects is an important question. So a quick recap for you that what will be the site of the lesion in different type of the visual field defect. Okay, so here the first one, the visual field is defective only in one eye, only in one eye. So this is right eye, this is left eye. So here the lesion is, this is a central scotoma type of the defect, and the lesion is in the right retina or right macula, as you can see. Okay, again the second one, the defect is only in the right eye, only in the right eye, the complete field loss is there. So monoocular field loss, complete field loss, this happens in the cases of the lesions of the optic nerve. When there are complete lesions of the optic nerve, that will lead to field loss on that side. Okay, the third one you are seeing, the temporal half of the field is gone in both eyes now, both eyes. So this type of the field defect is called as bitemporal hemianopia. So bitemporal hemianopia will be seen in the lesions of central optic chiasma. Most likely the pituitary tumors like pituitary adenoma, craniopharyngioma, they cause bitemporal hemianopia. Okay? Then homonymous hemianopia, when the half of the field is lost on the same side, the left half of the right eye, left half of the left eye is lost, that type of the field defect is called homonymous hemianopia. Okay, so here you see beta, here you can see the difference, no central sparing, homonymous hemianopia, no central sparing. So here the lesion is in the cases of optic tract, and the lesion, as I told you, will be on the contralateral side. Here in this image it is again left-sided homonymous hemianopia, so lesion will be in the right optic tract. Okay, if quadrant is gone, it means either it is temporal lobe or parietal lobe. In temporal lobe, it is pie in the sky, superior quadrantic defect on both sides, pie in the sky. So that is your temporal lobe. ठीक है, कोई ज़्यादा इसमें कॉम्प्लिकेट करने की बात नहीं है, just remember it in the simplest way बच्चे. ठीक है, if there is quadrantic defect in the inferior quadrant, that is pie on the floor, so that is seen in the cases of parietal lobe lesions, parietal lobe lesions. Okay, and here what was in our question, when there is homonymous hemianopia with central sparing, the macular area is spared, so homonymous hemianopia with central sparing or macular sparing, that is seen in the cases of occipital cortex. Again, the lesion will be on the contralateral side. So if it is left-sided loss, the lesion will be in the right occipital cortex. ठीक है? So that is the simplest way to remember your field defects and to attempt the question correctly in the exam, बच्चे. All right? Fine. So moving on to the next question, my dear friends. Expect the questions based upon the investigations in the ophthalmology exam, bache. So a diabetic patient underwent fundus fluorescent angiography. Fundus fluorescent angiography. So what is the grade of the diabetic retinopathy seen in these cases? Seen in these cases. As per the image here, bache. बेटा ड्रग्स तो हमने देखो अभी कर ही रहे हैं. वी डिड द ड्रग्स फॉर एंटीरियर यूवियाइटिस, वी डिड द ड्रग्स फॉर ग्लाकोमा, है ना? ठीक है, राइट? So you know what drugs should be given in glaucoma, you know what in which particular condition, and I'm coming to the other things as well, don't worry. Okay, right. A diabetic patient underwent fundus fluorescent angiography. What is the grade of the diabetic retinopathy as per the findings shown in the given image? ओके बेटा, पहले तो इमेज को ध्यान से देखें. फर्स्ट ऑफ ऑल लुक एट द इमेज केयरफुली. सो व्हाट यू आर सीइंग, पहले तो यहाँ पे तो ऑलरेडी बताया हुआ है कि एफएफए है. सो यू शुड बी एबल टू आइडेंटिफाई दैट दिस इन्वेस्टिगेशन इज एफएफए. सो एफएफए में क्या होता है कि आपका डाई जो है वो ब्लड वेसल्स में व्हाइट अपीयर होता है. द डाई अपीयर्स व्हाइट इन द ब्लड वेसल्स एंड द नॉर्मल कैपिलरी नेटवर्क इज देयर. If there is any leakage of the dye, that is abnormal. So here you can notice all these areas, friends. What are they looking at? As if some abnormal bunch of the vessels is there, which is leaking the dye. So this is the leakage of the dye from the new vessels. Neovascularization. So this is the leakage of the dye from NVD and NVE, bache. Neovascularization of the disc and neovascularization elsewhere. So once there is neovascularization, that is the stage of proliferative diabetic retinopathy. So this is how the fundus fluorescent angiography helps you to identify that what is the grade. Okay, what is the grade of the diabetic retinopathy. ठीक है? So I'm sure it is clear, no doubt to everyone. So this is the proliferative diabetic retinopathy. Okay, if it is mild NPDR, you will be just seeing some microaneurysms. So microaneurysms, they will be appearing as hyperfluorescent dots. Okay, whereas in severe and moderate NPDR, it will be more extensive areas of microaneurysms. There can be some areas where you can see the cotton wool spots in fundus fluorescent angiography. They will appear as areas of ischemia. Okay, so but once there is leakage from the blood vessels, that is your proliferative diabetic retinopathy. Fine, chal. So this is just the kind of again another image, enlarged image I have put for you. Okay, so moving on to another question here. A patient presents with anisocoria, bache. Read the question statement again carefully. Anisocoria. Anisocoria, what do we mean by anisocoria? Anisocoria means the size of the pupil is not same in both eyes. Okay, so normally the size of the pupil is same in both eyes. So if there is difference, significant difference, it is called anisocoria. So what is the finding on the examination? The left eye pupil is larger than the right eye. So left eye pupil is large. It constricts very sluggishly in response to the torch light. So the light response is very sluggish. It is also slow to dilate. So what is your diagnosis first of all, bache? Unilaterally large pupil. Okay, so unilateral large pupil, sluggish, slow to dilate, sluggish to constriction and slow to dilate. So means the pupil, the muscle, the pupil is tonic. It is sluggish, slow to constrict, slow to dilate. So that is a tonic pupil, right? So it is a case of AD's tonic pupil, beta. Remember, in AD's tonic pupil, it's unilateral problem most of the time. So the involved pupil is larger than the normal pupil. Tonic means कि pupil reactions जो हैं, they are sluggish. The pupil has become rigid. You shine the torchlight, it is slow to constrict. You show the near reflex, slow to constrict. You remove the light or the near target, it is slow to dilate because of the tonicity of the pupil. So the diagnosis is, yes, AD's tonic pupil. AD's tonic pupil. And what is the cause of the AD's tonic pupil, which is your question? Then what is the likely site of lesion in this condition? So mostly it is because of the involvement of the ciliary ganglion, parasympathetic postganglionic involvement or involvement of the ciliary ganglion, okay, which can be in the form of the mostly viral infections. So here the site of the lesion is ciliary ganglion, bache. Okay, the midbrain lesions, they cause AR pupil. If there is involvement of the sympathetic chain, there is Horner syndrome. Okay, if third nerve nucleus is involved, so that will cause efferent pupillary defect. Efferent pupillary defect. Okay, right? Yes, absolutely right. So pupil pathway and the lesions based upon the pupil pathways, again an important bache. You must have seen the questions, they have been asked in your exam. Okay. So if afferent pathway is affected, your optic nerve is affected, retina is affected, then we get RAPD. Okay. If the lesion is in the midbrain pretectal area, we get AR pupil, Argyll-Robertson pupil, in which light reflex is absent, accommodation reflex is present. If the lesion is in the level of third nerve nucleus, so that causes efferent pupillary defect. But there will be no problem in the dilation. Okay. If lesion is in the ciliary ganglion area, that will lead to AD's pupil, in which pupil is tonic. Okay. So again, simple few things to remember, but they can help you in attempting the question, bache. Okay, let's move on to the next question, bache. Which of the following is not correctly matched? So I have put this question because a similar question came in the INI-CT exam, though that question was of very, you can say, unexpected, out of our level, but a similar kind of the question, knowing about the lenses which are used for examination is not a bad idea. Okay, so at least for our FMG exam, we should have the information which is related to this question, bache. So have a look, which of the following is not correctly matched? So what are the statements? Vogue plus 90D lens used for fundoscopy on the slit lamp. Fundoscopy means fundus examination. Plus 20D diopter lens used for indirect ophthalmoscopy. Gonio 4 mirror lens used for angle of anterior chamber. Plus 20 diopter lens used for fundoscopy on the slit lamp. Fundoscopy on the slit lamp. So which one is not the correct match, beta? Which one is not the correct statement? Okay, so try to remember your examination methods. Try to remember your examination methods, bache. देखें, so what are your answers, bache? So you know, for fundus examination, either we can use indirect ophthalmoscopy, okay, or we can use direct ophthalmoscope, or we can use special lens on the slit lamp. Okay, special lens on the slit lamp. So the lens which is used most of the time for doing fundus examination on slit lamp is your Vogue plus 90D lens. Okay, so there are other lenses also available like plus 60 diopter lens, and 70 diopter lens, but mostly we use 90D lens. So this is correctly matched. Okay. Then in indirect ophthalmoscopy, we need a condensing lens. Again, mostly we are using plus 20 diopter lens. So this is also truly matched. Then when you want to see angle of interior chamber, beta, you want to use that procedure is called gonioscopy, and we use special gonio lenses. So gonio 4 mirror lens is one of the lenses which is used for angle of interior chamber. Okay? So that is again a true statement. 20D lens for fundoscopy on slit lamp, that is false, because 20D lens is used for indirect ophthalmoscopy. Fine. So the answer here is choice D. This is incorrectly matched. Okay. So little bit information about the lenses. You should know bache which lens is used for which examination method. Okay. So to make you remember, to give you an idea how these lenses they are used, see here you are using plus 90 diopter lens for fundus examination on slit lamp bache. Similarly, even we have the 70 diopter lenses as well, but plus 90 is the most commonly used lens. Okay? This is the 20 diopter lens, condensing lens, which is being used for indirect ophthalmoscopy. Fine. And to give you an idea, so this is the 4 mirror lens which is used for angle of interior chamber. So this is actually showing you whether the angles they are open or they are narrow or closed. So these lenses they are called gonio lens, 4 mirror gonio lens, 3 mirror gonio lens. They are the commonly used gonioscopic lenses for examination of angle of interior chamber. Okay? So sometimes if you don't even know all the choices, by exclusion, you know plus 20 is used for indirect ophthalmoscopy. So you can exclude the choice D as an answer even if you don't know about the other lenses. Fine? Okay? Chale. Moving on to another question. An industry worker presents an eye emergency with history of acid falling into the eye. All of the following are the likely complications in this case except. So acid injury, which will not be a complication seen in these cases. Again, a simple question. I'm very sure again you should be able to answer, because chemical injury complications management, again an important topic for your exam. So let's go to the choices. Symblepharon. Symblepharon is when there are adhesions between the palpebral conjunctiva and bulbar conjunctiva. So acids, they cause extensive damage on the surface of the eye, ocular surface. So symblepharon is a very common complication. So that is a true complication. Complicated cataract. So complicated cataract is a type of cataract which develops when there is secondary ocular disease. Most of the time it occurs in the cases of uveitis, in the cases of high myopia, retinitis pigmentosa, acute congestive glaucoma. But cataract which occurs because of the chemical injury is not called complicated cataract. So this is false. Limbal ischemia, yes, because the limbal stem cells, they are damaged whenever there is chemical injury. Okay. Ankyloblepharon, yes, that can again happen, the adhesions between the two lids, because the skin area, the conjunctival area is damaged because of the chemical injury. So there can occur adhesions. Fine. So here complicated cataract is the answer here. Okay, bache? So again by method of exclusion. So this also gives you an idea what are the complications which are related to chemical injury and what is the treatment. Treatment is to prevent these complications as much as possible, immediate copious irrigation of the eye surface with fluid till the pH becomes neutral. Okay, so try to prevent the damage by immediately irrigating the eye with whatever eye solution is available, whether it is normal saline, ringer lactate. If nothing is available, even initially with the tap water, and then try to double evert the lid to remove any chemical particles, and then you start the patient on antibiotics, anti-inflammatory, citrates, lubricating eye drops. Okay, the aim is to prevent the complications as much as possible. Fine. Okay. All right. Coming to your next question, beta. Again, a simple question, but where you need to kind of integrate your information which you have about ophthalmology. Sodium fluorescent dye can be used in all of the following procedures except. Sodium fluorescent dye can be used in all of the following procedures except Goldmann applanation tonometry, John's dye test, lens capsular staining, corneal ulcer. So in ophthalmology, you know, fluorescent dye is used when you want to do the Goldmann applanation tonometry. Remember? Right? So you're putting a drop and then you're trying to fuse the Myers. John's dye test is one of the tests for NLD obstruction, where again you are putting a drop of fluorescent in the eye and then you are checking that whether the tear flow is normal or it is obstructed. Lens capsular staining. Lens capsular staining, that is a step in the cases of the cataract surgery, beta. If there is mature cataract, you want to do the staining of the capsule so that you are able to do the capsulotomy easily. So in those cases, we are not using the sodium fluorescent dye, we are using the trypan blue dye. ठीक है, यहाँ बेटा शायद आपने एक्सेप्ट नहीं पढ़ा है. And corneal ulcer, because sodium fluorescent will always stain the area where there is epithelial ulceration or abrasion. So sodium fluorescent dye is used in the cases of corneal ulcer. So true. So the answer here is bache, choice C. Choice C. Yeah, right? So are you clear now? So trypan blue is the dye which is used for the lens capsule, beta, not the fluorescent. Okay, fluorescent is used for Goldmann applanation tonometry, corneal ulcers, corneal abrasions, for dry eye staining, also used in John's dye test, also used in fundus fluorescent angiography test, but not for the anterior capsular staining. This is we are using trypan blue dye, beta, for the capsulorhexis or for the anterior capsulotomy. ठीक है, right? चल. Okay, moving to the next question, beta, which is related to your extraocular muscles. Which is the muscle responsible in the left eye for movement in the dextrodepression gaze? Okay, so they can ask you the question about the muscles. The eye is in dextrodepression gaze, that is a right and down position. So which will be the muscle responsible in the left eye for this movement? Is it left inferior rectus, left superior oblique, left medial rectus, right inferior rectus? So what is your choice, bache? Okay, so if you want me to show what is the dextrodepression, so this is the position, bache. Dextrodepression. Okay, dextrodepression, the eye is down and in the right gaze, right down gaze. So left eye and right eye. So you have to tell me which is the muscle which is acting in the left eye, in this condition. Left eye, beta. The eye is going down. So and towards the right side. So in the right eye, it is your inferior rectus which is acting, whereas in your left eye, it is the superior oblique which is acting, beta. Okay, so this is one of the cardinal positions of the eye. So one particular muscle will be acting in this position. So if it is right and down, so right eye inferior rectus and the yoke muscle in the left eye will be superior oblique. Not medial, beta. Medial will cause only towards the right side, adduction. Here it is down and adducted. Okay, right and down. ठीक है डॉक्टर द्विवेदी? Medial rectus is not the answer here. The answer here is left eye superior oblique. ठीक है? All clear here? So these are the cardinal positions of the eye. So one muscle will be acting in this position. So when the eye is in down position and adduction, so there will be superior oblique which will be the acting one. Okay, and you can, like, the question can also be in the form of the yoke muscles. So basically here I am not asking the yoke muscle, I am asking the muscle only in one eye, but the question is to be attempted in the same way we do the yoke muscle. So if it is dextrodepression, right eye inferior rectus and left eye superior oblique will be the muscles which are acting in the right and left eyes respectively. ठीक है? सो अगर एग्जामिनर थोड़ा ट्विस्ट करके क्वेश्चन डाले तो भी डोंट वरी, जस्ट गो थ्रू योर कंसेप्ट्स वही रहेंगे चाहे क्वेश्चन किसी भी फॉर्म में डाला जाए बेटा. दैट इज वेरी इंपॉर्टेंट टू रिमेंबर. कीप कॉन्फिडेंस ऑन योर सेल्फ. ठीक है, आपने सब कुछ पढ़ा हुआ है, you have read everything by now, you have revised most of the things, so trust your concepts बच्चे, trust your concepts. Question statements may be little twisted, the question statement may be little indirect, but try to find out your answer based upon your concept. You will always find. So here, that's why I put this question, not asking about the yoke muscle, just asking about one muscle in one eye. So the question is in the same way as there. Similarly, they can ask you about the drugs. So drugs, if it is fungal ulcer, you know it is going to be antifungal drugs. If it is viral ulcer, viral keratitis, you know it is going to be antiviral drugs. Okay? So even for the drugs, do not get kind of intimidated that why it is being asked in this way. So you already know, but try to just imply that knowledge during the exam, bache. That's very important. Okay? Fine. Let's move on to the next question for you. A young patient comes to IOPD with history of frequent change of glasses. On retinoscopy, a scissoring reflex is seen. Again, all the things which you have already read. History of frequent change of glasses. On retinoscopy, a scissoring reflex is seen. Scissoring reflex is a feature of irregular astigmatism. That is the feature of irregular astigmatism. And irregular astigmatism is never satisfactorily corrected by the glass prescription. So that is why frequent change of glasses. Following findings are seen when the patient looks down. What is not a treatment option in this case? So not word is very important. Again, always read the last line of the question statement very carefully before jumping on to your answer, bache. So what you are seeing here, again, I am very sure every one of you can identify this particular sign. When the patient is looking down, because of the conical cornea, there is a V sign in the eyelid. So this is your Munson sign. This is your Munson sign which you are seeing here. So diagnosis is clear to everyone. Irregular astigmatism, scissoring reflex, Munson sign. The diagnosis is keratoconus. So which of the following is not the treatment of keratoconus? Which of the following is not the treatment? Intracorneal stromal rings, collagen cross-linking, rigid gas permeable contact lenses, or LASIK. Okay, so you know intracorneal stromal rings or Intacs, they are used when there is corneal thinning and cornea needs mechanical support. Collagen cross-linking or C3R procedure or CXR procedure is done to remodel the collagen, corneal collagen, and to stabilize the progression of keratoconus. Rigid gas permeable contact lenses or RGP lenses, they are used when we do not want, of course, to correct the irregular astigmatism, you don't want to give the glasses, you will rather prefer giving rigid gas permeable. Now LASIK is an absolute contraindication. So LASIK, as you know, bache, is absolutely contraindicated in the cases of keratoconus, because in keratoconus already the cornea is getting thinned, the refractive error is not stable, LASIK is going to worsen the condition. So any refractive procedure like LASIK is contraindicated in cases of keratoconus. So that is your answer in this case, bache. All right. Fine. Moving on to the next question, beta. A 7-month-old child is brought by the parents to eye OPD for suspected poor vision. All of the following tests they can be used to assess the visual acuity in this case except. Okay. So basically what the question is asking, how to test a vision in 7-month-old child. So 7-month-old child is a child which is pre-verbal, that the child is not able to express by telling that what the child is seeing. So it's a pre-verbal stage, right? So here you have to go in for objective testing of the vision. So which will be the test which can be done? So we can do optokinetic nystagmus. Yes, that's an objective test for pre-verbal children. Allen's picture cards. Now you show picture cards to the child and you expect the child to match the cards or to tell that whether this will be the same picture is not possible for a child who is just 7 months old. So this is not the correct test in this age group. Teller's preferential acuity test, yes, that can be done. Visual evoked response, yes, that can be done, because these are the 3 main tests which we do for testing vision acuity in age group of less than 1 year, which is considered a pre-verbal age. So using picture cards or using the charts, that is not going to be a correct method of assessment in this age group, beta. ठीक है, right? नहीं, C नहीं बेटा, C नहीं, Allen's picture cards. Teller's preferential acuity test में क्या करते हैं? As you see here, so this is Teller's preferential acuity test. You show the child 2 kind of the slides, you can say. One the plain pattern and the second one which is having this lines or a patterned picture. So the child which is having normal vision will be more focused on the pattern. So that is why the preferential acuity. The child will prefer to focus on the pattern if the vision is normal. Okay, and this is the optokinetic nystagmus drum, where you are kind of moving this drum which has again black and white stripes. Normally when the child is able to focus on this drum, there should be a normal physiological nystagmus visible in the eye of the child. If the nystagmus is present, it means the vision development is normal. Similarly, you can do visual evoked response or visual evoked potential test to check the electrical activity in the visual pathway. ठीक है, picture cards नहीं use करते हैं बेटा. ठीक है, okay. Moving on to the next question, bache. Again a simple question, but just kind of giving you concepts related to this. Which of the following refractive state is shown in the given optical diagram? Questions based upon the optical diagrams, bache. Again, 1 or 2 questions have been coming in every exam related to refraction. Which of the following refractive state is shown in the given optical diagram? So what you are seeing here in the optical diagram? So you are seeing first of all that the light rays, they are focused on the retina. Okay, so light rays are focused on the retina. If they are focused on the retina, it means it is already a corrected refractive state. Fine. And what type of the lens is in front of the eye? What type of the lens is in front of the eye, beta? The shape of the lens आपको क्या बता रहा है? Biconvex lens. Biconvex lens, which is a converging lens. So plus lens or a converging lens is used in the cases of hypermetropia, where converging power is less. So you are giving a convex lens so that the light rays, they can focus on the retina. So that is a case of, very nice, most of you have given the correct answer, corrected hypermetropia. Okay, so for myopia we use concave lens. If the light rays, they are not on the retina, it means it is uncorrected. So in hypermetropia they are behind the retina, in myopia they are in front of the retina. So that is how you can identify from the optical diagram the refractive state. For regular astigmatism, when the two meridians, they are having different powers, so in those cases the optical diagram is in the form of a sterum conoid, because then the two meridia, they are not focusing on the same point, they are focusing at the different point. So you know the sterum's conoid for the regular astigmatism as well. So these are the kind of the optical diagrams, they can ask one of that to you. ठीक है, ये पार्ट भी हो गया. Okay, let's do a question based upon your surgical instruments. Which of the following instrument is not used in the cataract surgery? Okay, the purpose of this question is to give you a revision of the surgical instruments, bache. Which of the following is not used in the cataract surgery? Instrument shown in figure A, B, C or D. Again, a very simple question, not a very complicated one. So what is your answer here, bache? So in figure A, you are seeing, yeah, be confident beta, why question mark? You are very right, Dr. Dwivedi. So cataract surgery is an intraocular surgery. Okay, so where you are entering the anterior chamber, you are doing the surgical steps. So have a look here. Have a look here. So figure A is showing a very fine forceps, which is plane, which is angled. This is your McPherson forceps, beta. This is your McPherson forceps. So McPherson forceps, in the cases where you want to use the rigid intraocular lens, you can hold the intraocular lens with this forceps as well. This forceps is also used for helping in the suturing. Okay, look at the figure C. Figure C is your corneal scleral forceps, lens corneal scleral forceps. So this forceps has a very fine teeth to hold the corneal tissue or the scleral flap. So this is again used in cataract surgery, keratoplasty, in glaucoma surgery. And what is this figure D? Figure D is your eye speculum, the wire speculum. So eye speculum is needed because you have to keep the eyelids open during the intraocular surgery. Whereas this B is a clamp. You can see there is a plate and there is a ring. So it's a clamp. So this is a Clasion clamp. Okay. So obviously Clasion clamp is not used in the cataract surgery. It is used for incision and curettage of the Clasion. So B is your answer, as you are already telling. Be confident. Don't be have any doubt. That is the right answer, bache. Okay. Clasion clamp is used to hold the Clasion during the incision and curettage of the Clasion. Fine? Okay. Let's move on to the next question, beta. This is your drug related question. Now that will help you to revise your drugs as well. Let's do this. A young boy presents with red eye and the following lesions in the eye. There is a recent history of tuberculosis in father. Which of the following is the drug of choice in treatment of this case? Okay, so to know the drug of choice, first of all, you must make a diagnosis. So red eye hai, and what are you seeing over here? You are seeing nodular lesions which are close to the limbus. Nodular lesions close to the limbus. There is a history of tuberculosis in the family. So this type of the inflammatory limbal nodules, they are seen in cases of, especially when there is exposure to tubercular antigen. Your diagnosis is, first of all, bache, don't jump to the treatment. Make the diagnosis, only then you will be able to attempt the question rightly. This is a case of phyllectanular conjunctivitis, बच्चे, phyllectanular conjunctivitis, right? Now, phyllectanular conjunctivitis is type 4 hypersensitivity reaction. So, mast cell stabilizers, antihistaminics, they will be effective mostly for type 1 hypersensitivity reactions. For example, in cases of VKC, the question which you got in your last exam, ठीक है, कि आप mast cell stabilizers दे सकते हो, antihistaminics दे सकते हो. So those are used for type 1 hypersensitivity allergies, VKC, seasonal allergies, giant papillary conjunctivitis. So there they will be helpful. But in phyllectanular conjunctivitis, it is type 4. So you need a strong anti-inflammatory drug, which is your topical steroids. Okay? So that will be the answer if they ask the drug of the choice for phyllectanular conjunctivitis. Right? Oral steroids are not needed because the inflammation is mostly in the superficial area only, in the conjunctival tissue. So topical steroids will be the drug of the choice in cases of phyllectanular conjunctivitis. Fine. So topical mast cell stabilizers, antihistaminics, they will be used in VKC, vernal keratoconjunctivitis. You can also use them in GPC, giant papillary conjunctivitis, or seasonal allergic conjunctivitis. Correct? Okay. Okay. Moving to another question, which again is a kind of repeat, but again almost every time this question is asked. So let's not skip it and do it there. I'm very sure you'll be able to do this question, all of you, correctly. A man had a road traffic accident and presents in emergency with periorbital ecchymosis, subconjunctival hemorrhage, and ophthalmos. Okay, so again all the features: periorbital ecchymosis, subconjunctival hemorrhage, and ophthalmos. The CT orbit shows the following image. So CT showing teardrop sign. I'm again very sure all of you cannot make it wrong. If you have not done that, do it now. Then you see orbital contents herniating into the maxillary sinus in the form of, which is typically called teardrop sign. You know it is the fracture of the floor of the orbit, and it is the blowout fracture of the floor of the orbit which produces this particular sign. Okay, and because of this content herniation, the eyeball moves inward. There is inward displacement of the eyeball leading to anophthalmos. So these patients, they will be presenting with anophthalmos. Okay, so it is blowout fracture of the orbital फ्लोर बेटा, ठीक है. मीडियल वॉल नहीं है क्योंकि मीडियल वॉल में एंट्रम में नहीं जाएंगे कंटेंट, ठीक है. इट्स नॉट द नेजल बोन फ्रैक्चर और lateral wall fracture. The typical teardrop sign will be seen in the cases of orbital blowout fracture of the floor of the orbit, ठीक है ना. So again a very very simple repetitive question, but if you get in the exam you should be able to make it correct. Okay, the next question, bache. A child is found to have refractive error of +1 diopter sphere in right eye, +4 diopter sphere in left eye. Best corrected vision is 6/6 in the right eye, 6/36 in the left eye with glasses. So what is the next step in the management of these cases? So again, this kind of question in different forms has been always asked. Okay. So patient first of all is having significant difference in the refractive error of two eyes. Okay. So what is that called as, bache? When there is a difference of more than 2.5 diopter sphere between the two eyes. So that is known as anisometropia. Okay. So this child has anisometropia. All right. So you gave glasses to the child. But even with the glass correction, the vision in the left eye is not coming to 6/6. It is still decreased. So it means there is suppression of the vision in the left eye. So the child is having amblyopia as well. So there is anisometropic amblyopia. So you have already given the glasses. So what should be the next step? So what is the management of amblyopia? Basically, that's what they are asking. The management of amblyopia is that you want to stimulate the eye which is suppressed. You want to stimulate the eye which is lazy. So that is done by patching the normal eye. You occlude the normal eye so that the lazy eye is stimulated. So occlusion therapy, choice A is the right answer here. Okay? That is the answer there, right? So contact lenses, whether you give glasses or contact lenses, that depends upon the age of the patient. But even with contact lenses, you will have to give occlusion therapy. Squint surgery is not indicated in the here. Number one, they have not mentioned that whether there is squint or not, right? So here the question statement is that there is anisometropia and amblyopia because of the anisometropia. They have not mentioned squint in the there. It's not necessary that every time the child has hypermetropia there will be squint. Okay. Repeat refraction after 6 months. Yes, we will be repeating refraction after 6 months, but you will not just wait for 6 months. You will start the occlusion therapy because occlusion therapy is the mainstay of the treatment in the एग्जाम बचे. ठीक है. Now regarding images, beta, see there are few classical fundus images, few classical images of the slit lamp. So those of you who have are Miss students who have done the classes with us, revision classes with us, so we have done images so many times. So I don't think there should be too many confusion in the images, because most of the images which are actually asked in ophthalmology, they are very, very classic images. Okay, so I will suggest that go through the I'm not sure whether you are there in MIST with us. So go through the image revision which I did in my revision class in Ophtha. So even if you do those many images, they should help you to go through the exam part, beta. ठीक है, right? All right, so coming to the last question here, which is again partly your drug question as well, and if you want me to go through the drugs quickly, I can just go through that as well. So what is not true for the condition shown in the given image? So again, so this is telling you about the image as well and about the management as well. So the question is asking about which is not true of the condition given in the image. Now this particular image, for example, this is a spot diagnosis. Okay, so here what you are seeing, that the eye has been stained with the fluorescent dye. Okay, because once the cornea takes up the dye, that area appears green in the cobalt blue filter light. So this is showing a typical dendritic ulcer in branching pattern. Okay, a dendritic ulcer in branching pattern. So again, a very, very classic picture. So if you see it once, try to remember it. So when the lesion is stained green in color, dendritic pattern like branches of the tree. So this is dendritic ulcer. Dendritic ulcer is caused by herpes simplex virus. Now, question is asking us about to give a false, what of the choices is false statement for this condition. Topical steroids are contraindicated. So, this is true because dendritic ulcer is an active viral involvement of the epithelium and stroma. So, if you give steroids in active viral infection, that is going to do worsening of the ulcer. So topical steroids are contraindicated in dendritic ulcer. This is true. Topical acyclovir is the mainstay of the treatment. Acyclovir is antiviral. So dendritic ulcer is caused by virus. So topical acyclovir will be the mainstay of the treatment, beta. This is the true statement. corneal sensations are normal. Now this is false because corneal sensations are decreased in viral keratitis. Okay, they are decreased in viral keratitis. Fluorescent staining is used to monitor the healing. Yes, so because as you give the treatment, the infection heals, the epithelium becomes normal, so the size of the ulcer will become small, and gradually when the epithelium completely heals, there will be no staining on the corneal epithelium. So fluorescent staining will help us to monitor the healing. So that is again a true statement. So the right answer here is C, because that is false. Corneal sensations, they are decreased in the cases of viral keratitis. ठीक है बेटा, the corneal sensations, they are decreased in the cases of the viral keratitis. So this is how you attempt your questions, बच्चे. So everything beta you have done. Okay, so at this moment I know when you are so close to the exam, there always creep doubt in your mind, confusion in your mind, that whether I'll be able to identify the images or not, whether I'll be able to remember the drugs or not. So if you see, as I told you, the images, they are mostly very, very classic. Remember the fundus images of the diabetic retinopathy, central retinal vein occlusion, central retinal artery occlusion, retinal detachments, in the cases of, mostly in the cases of bullseye maculopathy, retinitis pigmentosa. So these are few classical fundus images. Then you should be able to identify the images of the corneal ulcers, of the conjunctival conditions like VKC, in cases of trachoma, in cases of phylactanular conjunctivitis, pterygium, again classical pictures. Okay. Similarly, the images in the lids, the lesions of clesion, stye, tracheasis. So these are the ones which you need to know. So just go through them and you'll be able to attempt them correctly. Regarding the drugs which you told, so drugs mainly in ophthalmology, they are going to ask about the anti-glaucoma drugs, beta. You have to know the indications of the anti-glaucoma drug and contraindications. Okay, so based upon that you can pick the correct drug. Similarly, management of acute congestive glaucoma, so mannitol, pilocarpine. So these are the few drugs you know what are given and what are contraindicated. Atropine is contraindicated in acute congestive glaucoma. Then the drugs related to corneal ulcer. So in any active corneal ulcer in which there is epithelial involvement, steroids are contraindicated. So if it is acute bacterial ulcer, fungal ulcer, dendritic ulcer, steroids are contraindicated. And you will give antifungal for fungal ulcer, antiviral like acyclovir for viral ulcers. Bacteria, you give broad spectrum topical antibiotics. In all the cases of corneal ulcers, you will also add atropine. Why? To stop the to better relieve the inflammation as well as the ciliary spasm. So that helps in healing. Similarly, in uveitis, interior uveitis, the mainstay of the treatment is topical steroids for anterior uveitis, plus again atropine, cycloplegic, which reduces the inflammation, which reduces the formation of posterior synecdoche. So these are the things. So if you have the concepts correct, you will be able to attempt the questions related to the drugs as well, bache. You don't need to really cram up the things. Okay? Right? Oh, absolutely. That's lots of congratulations to you, Dr. Pradhan. And a very all the best to all of you beta who are appearing for the June exam. Again, I will emphasize just one thing. I mean, my only motivation to you, you can say my only humble request to you at this point of time is, do not let the self-doubt overcome your hard work, bache. You have put in your hard work. These are the few days where you have to continue in that hard work while attempting the questions, while attempting the mock test, while going through the revision. There will be a lot of self-doubts coming, but do not let these self-doubts demoralize you. If anything, any question you are attempting wrong during this discussion, during mock test, take it as a learning. ये फाइनल एग्जाम तो नहीं था, फाइनल एग्जाम तो जून में होना है. So take it as a learning so that you do not repeat that mistake. Okay, so purpose of all the revision, purpose of doing question is that we do not repeat the mistake. So trust yourself, trust the learning which you had, trust what concepts we build. If you attempt something wrong, just rectify it and try to remember it. Okay, so our blessings from the whole of the Miss team, from me, all the very best. I'm sure you are going to come up with the flying colors. Okay, I hope this revision session has given you a good, this question session has given you a good revision of the ophthalmology and gave you an idea of about how to attempt the image based, clinical based questions. And I'm very, very sure that very soon we'll be interacting and congratulating you on your success in the exam. Beta. Okay? God bless you. Take care of yourself. And as I told you, hard work is going to overpower any kind of self-doubt for you. Okay? So keep working hard. God bless you, beta. Thank you so much.